to turn this on so maybe you can hear me better. Can everyone hear this? You need it turned up a little bit more? It's good? Okay. I have lost my voice at the second hour of teaching on occasion when I'm shouting too much, so I will try to make it all the way through for you today. And I'm going to move back and forth just a little bit so Ashley can get the camera range figured out. And is everything good if I'm standing here?
No, you're a little out. There you go.
Okay.
That's good.
All right. So, thank you, Ashley.
No
Appreciate
problem.
it. And it's recorded?
Mm-hmm.
Okay. All right. Thanks for putting up with the details. I'm Laraine Crampton. I've been teaching this course, as I mentioned earlier, for 10 or 11 years now, and over that time, it has changed. Okay. When this course began in the 80s, it was at the behest of our profession, as well as the cooperation of the Centers for Disease Control and the Office for Occupational Safety and Health. Okay. What was happening in the 70s and 80s was a lot of confusion as practitioners who had been quietly practicing here for a long time were trying to figure out how to be visible, as people who were being trained and coming here specifically to practice Chinese medicine were trying to figure out how to be visible, as medical doctors were like, those people don't even wash their hands. And as people sort of emerged sometimes from the shadows, sometimes from stores in a local Chinatown where they were sharing space with a pet store or with a massage parlor or whatever, to more visibility and more professionalism. So as the licensing initiative under Governor Jerry Brown all those years ago moved forward, so also nationally did the awareness that practitioners needed to be professional, needed to understand germs, disease transmission, protection against disease. Another thing that happened in the early 80s was this strange, horrifying, scary, mysterious epidemic of people dying mysteriously from a strange disease that seemed, to have no boundaries, barriers, whatever, which was HIV/AIDS. Okay, and the impetus to figure out how is this transmitted, how do people get it, do they get it from needles, what happens here, and hepatitis was, rampant in the 60s and 70s. Relatively speaking, and how is that getting transmitted, and how can we prevent that? So a lot of this all came together with the growth of our profession, and the Occupational Safety and Health Administration and the Centers for Disease Control and our profession got together and said, okay, what can we do to protect the public, to educate our practitioners, to protect our practitioners so that they don't get their career shortened by hepatitis B, or later we discovered other hepatitises that would have impact, or how do they not get their career and their lives shortened by HIV/AIDS. Okay, so from there, this course has developed. All right. When I took the class 17 years ago, I believe, I stood in line in Sacramento with 500 other students, and we literally had our coats, our books, our kits, our, everything that we brought, our lunches, and we stood in long lines. I think there were either 5 or 6 long lines, so like 100 people per line, and we stood in line with our stuff until it was our turn to go up to the examiner, and then we'd drop our stuff, face the examiner, open our kit, and go through the practical exam. It was a cattle call. It was uncomfortable, it was cold, and it was scary because everything depended on that few minutes when you suddenly stood in front of the examiner. All right, so since then the course has come down in scope, well, not in scope, it's gone up in scope and come down in size very specifically, so we now have usually only 50 students per class. This class is one of the rare ones that was allowed to go a little over 50 because there wasn't a course coming up anytime soon that others could get into. So we had allowed for 53 students. As it is, I believe we've got just 50 registered today. So, but that's the largest we allow anymore, so that you can have the experience of sitting in a focused lecture, being able to ask your questions, being able to go through the material in a coherent way in the morning, and then in the afternoon having coaching, and we'll go through the schedule in a second, having coaching before you take the exam so that you go in with a maximum of confidence that you're ready to roll, okay? Then when you take the practical exam, it's one-on-one in a quiet room without hordes of people distracting you. So you'll notice others in the same room taking the exam, but at no point will there be more than 6 people taking the practical exam at one time. So it's come really down to make it much more human for you, and we want you to succeed today. So let's see, what else do you need to know? I teach at Yosan University, and I supervise in the clinic, the community clinic at Yosan, where I've been doing that also for 10 years or so. So, the course. Let me figure out how I can get back and forth here. You've already met our administrators. Our examiners will be coming around midday to join us. Some of them will come in and watch the last part of the lecture to make sure they're up to date on what the latest revisions on the material are. And you will meet them this afternoon. Should there be, some of you were wakened at 3 o'clock this morning by an earthquake, should there be a similar occurrence, what we'll do is we'll head immediately for that exit and get as far from the buildings as possible. If you feel that you need to cover in place under a table or near a triangle wall where you could hope for protection, that's acceptable, but primarily get out of the building. Also, if there are any other emergencies, any other reason we would need to evacuate the building, we would go out the emergency door there and the entrance that you came in and go out to the courtyard as far from the building as possible until it's okay to return to the building. But I've never had a course interrupted, and I trust that this one will not be interrupted either. Okay, so you should have this edition of the manual. Going forward from this class, there will be a new manual. So this is the last class that's using this manual. And some of the details in this manual you'll notice are a little out of date. And as soon as the new manual comes out, it also will be out of date, given the nature of the statistics we're tracking, the nature of the reporting through the CDC, through health departments and that sort of thing. So what we're doing right now is the most recent approximation of the facts that we can get our hands on. The next edition will be a little bit more current, but the material, the science in this edition is still good. So we will proceed confidently on that. All right, so you've been through registration. The lecture has just begun. I normally don't give a break because what happens during a formal break is people disappear and ignore the timeline for coming back. So if I usually give a 15-minute break, people don't come back for 25 or 30 minutes and therefore either delay the class or miss the lecture. I would prefer that you do neither delay nor miss the lecture. So for purposes of sparing my voice, I probably will give a brief break. However, what you should plan to do is if you need to use the restroom during the morning or if you need to attend to some issue with the administration as far as picking up your phone to check on childcare or something like that. Take your own initiative to do that. So when we actually take a break, it should ideally be a reading break where you get a few more precious moments with your book, okay? So I'm not going to be upset if you get up and leave to go to the restroom, or if you need to take a few minutes to cough outside or something like that. Do that freely. And then when we do take a break, it's not going to be a restroom break as such. It'll be more so that you can read your books, I can rest my voice, and those few people who do need a restroom break during that time can take it, okay? Otherwise, we'll have lines and lines. Blah. All right. We will most likely take a break following the lecture for 10 to 15 minutes for me to meet with the examiners and to update them on any content that's come for this course that they haven't had contact with yet. That will be probably a 15-minute break again. And that break is where you can haul out your lunch, read your book, whatever you want to do. There will not be sufficient time at any point in the day for you to leave the campus, go to a restaurant, sit down and get food, okay? I wish that we had snack facilities here. As far as I know, we don't. Does anybody attend this school that could inform us? Okay. Are there any facilities where snacks are available on a Sunday?
Yeah. There's a
No.
vending machine.
There are vending machines. Are they available?
Yeah.
Yeah,
There should be a lot.
Okay. All right. So you might be able to grab something from a vending machine, but there really won't be time, unfortunately, to leave the campus, go get something to eat, and come back. So please don't plan on that. If you brought snacks and lunch, I'm perfectly open to you having those when you need to have them, as long as they don't send everybody out of the room because of the fragrance of your snack, okay? So take your own responsibility for your blood sugar, okay? All right, now, this looks pretty weak to me. Can everybody see it? Should we turn off some forward lights so that you can see it better?
Sure.
Okay. Andrea, you know where the panel is, I think.
I know. But I will find
Okay, students who do know where the panel is? Front. There we go. Is that better?
Yep.
Is that better?
Yeah.
Or is that just hard to read?
Will they be able to see me on the video?
Yeah, they can see me. If they can't, we'll change the lighting for the second half. We'll go this way the first part, okay? All right. You guys good? Thank you. Okay, so after that brief break, what we'll do is we'll come back and we'll do a demonstration of the practical exam so everybody can see. One of the examiners will sacrifice his pride and be a student who makes mistakes going through the practical exam so that you can see how to go through the exam, you can see how to recover if you make a mistake, and we can discuss some of the practicalities of the exam at that point, okay? Then we change the schedule a little bit. So the coaching we're going to put right after the demonstration. So you see the demonstration and then you immediately have a time of coaching so that you can put together in your head all the details of how to get through the practical exam in one flow, okay? And what we'll do is we'll break up into groups, and that coaching will be on an individual level, 8 or so people per group, and you'll go through the whole practical exam again with one of the examiners coaching you. Okay? Then we'll get back to the written exam, which will take place in this room. So things move pretty quickly, and this morning when I'm saying mark that in your book because you want to come back to it, the only time you're really going to have to come back to it is in the brief break in the middle of the lecture and in the brief break before the demonstration. After that, you won't have access to your books anymore because we'll be moving right along. So do take those breaks. I just want you to know in advance that's when you can get back to your book. Okay. All right. From the written exam, you'll have 45 minutes to take it. The exam I'll explain in great detail. how to go about it, all that sort of thing when we get there. If for any reason you don't pass that written exam on the first time, don't panic. We have additional copies of the exam. You'll have the opportunity to take it a second time. Okay? So if you don't pass the exam the first time, you'll be informed quietly in private, and you'll have the opportunity to study and retake the exam. Following the written exam, success for all of you, I hope, then you'll wait probably out in the courtyard. If there's no one needing to retake the exam, we may let you wait in here. But if there are people retaking the exam, they really need quiet, and you guys will really need to like cut loose and look at your kits and talk about things. So we'll probably let you do that in the courtyard if there are people needing to retake the exam. So the practical exam, most of the time you'll take it roughly in the order that you finish the written exam. Okay, now I say roughly because it's not worth sacrificing points on the written exam to rush to be first in line, because there's going to be a delay anyway as we grade the exam. So there'll be a waiting period, and it's really no prize just to be first in line to take the practical exam. So don't rush yourself, but what we do try to do is respect that these people finished first, and so we'll try to make sure that the first people go first on the practical exam if they are ready to do so. Okay. With the practical exam, we'll go through the rubric very carefully so you know how to pass the exam, you know how to recover from mistakes, or if you do not pass the exam, you'll know how to go back and prepare again for one retake. Okay. So in both instances, you have two chances at this exam, the written and the practical. And my experience in the last few courses has been, actually the last course we had a 100% pass rate. In a previous course, out of 40 students, 39 passed. One student had to take one of the exams a second time in order to pass. So, you know, pretty high pass rate, and I like it that way. And that's one reason I teach so thoroughly and as precisely as possible. You may experience it as a little slow, but students tell me afterwards that the information really gets in. So hang in there with me, okay? All right, so after the practical exam, you'll be given an evaluation form to fill out on the day. You'll be able to make comments on your examiner, your coach, etc. if you want to. And any comments that you have regarding improving the course in the future if you wish to lodge those comments. I will say that the entire course is going to change in July when we roll out the new manual and the new PowerPoints. So, yay. All right. Having turned in the evaluation, you're not quite ready to leave yet until we have certified that the exam is secure. Okay, Andrea mentioned at the beginning that if one person violates the security of the exam, that everybody has to start all over again, and on a different day and time, and with the new manual. Okay, so we take very seriously making sure that today is successful. So we need to know that you are not using your cell phones, that you are not recording anything, that you are not communicating by texting with anybody outside the exam, etc. Once we have accounted for every copy of the exam as it's been distributed, as it's been taken, graded, etc., then we can certify that the exam is secure. What we will do is make sure that you don't leave until you know that today is going to count for you. Okay, so if it takes us a few minutes longer to secure the exam after you've already finished everything, we appreciate your patience in just waiting until I can announce, yay, everything's good, you can go. Okay, so hopefully that will be sooner rather than later. All right, so any questions on this part of the day? Nope. Okay. Well, let's let's get moving. As we go through the day, I'm going to be using the manual quite a bit at first, and I will probably say things like, oh, on page so-and-so, paragraph such and such. But as we really get rolling towards the end of the day, I just whip on through by memory, and I'm forgetting page numbers and forgetting which paragraphs. So those of you who are tracking through with me through the manual, I may say, okay, where is that? And somebody could shout out page 54. I'd really appreciate that. Okay. So we've already covered most of the material in the preface. Okay. The course itself has evolved and evolved. We used to talk about hepatitis. You know, when I took the course 17 or 18 years ago, the discussion was on the bad hepatitis B. You know? Well, since then we've really gone through the alphabet and we've come up with not just the okay hepatitis A, which isn't too horrible, but also B, C, D, E, etc. Likewise, this manual has expanded in its understanding, and the course has expanded in its understanding of how do medical professionals behave around issues of cleanliness, around issues of disease transmission, around understanding bloodborne pathogens, which is why OSHA and the CDC really wanted to get on board with us to help us really grasp those in a very strong way. Okay, so I have no light. Okay. We'll just see if I can read this book. If not, we may have to turn the lights back on. All right. Part 1, page 3, pathogens. All right. We're talking about mechanisms of disease transmission today, among other things, and the characteristics of infectious diseases like hepatitis and HIV. Okay. What we are not doing today is covering, thank you, you're fantastic. What we're not doing today is covering every infectious disease under the book. Okay. So a couple or 3 months ago, someone in the course really wanted more information on a particular disease and kept actually interrupting to go, but could you talk about this? Well, no. We're going to focus on a fairly limited range of things today, and then the rest of your investigation into various viruses and that sort of thing will take place in your pathology courses or in your postgraduate training. Okay, this course will have a very specific focus. Okay, so mechanisms of disease transmission. On page 5. Let me catch up with the slides for a second here. I skipped over this. The purpose, history, objectives of the course. Well, the objectives that we want to follow through on are to teach you content, to teach you relevant information and science related to these topics, to train you in particular skills that you will need throughout your career, and then to test you on those. So that's our objectives for today. Teaching in the morning, training midday, and then testing through the afternoon. It's a pretty clear progression, and we try really hard to make it very clear for you as well. Okay. Now, we're going to be talking a lot, starting on this page 5, about the biomedical risks of infection. Eventually we'll get to some important definitions, and you'll notice that I'll whip through those definitions because many of them I've defined as we've gone through the first part of the lecture. So don't be amazed if I go through some of the slides really quickly. We've got over 100 slides to get through in a short period of time. We're going to talk about basic principles of C&T, and that again I'm going to go through really rapidly because we're going to go through it very thoroughly in the demonstration and in the coaching. So it'll keep getting layered in through the day, and the layer in the lecture is going to go pretty quickly because we'll come back to it in great detail. Okay. We are going to talk about some additional safety considerations, such as how to set up your office, or a home visit, or a field station if you were doing public health care. So we'll talk about some of those considerations. We'll talk about how to make sure that your office is safe, not only for you, but also for your employees and their families and anyone who visits your office, as well as for your patients. Okay. Along through that, and by the time we get to these latter topics, we'll have covered a lot of the information and we'll just be visiting them again. Practicing in travel settings, practicing in public health settings. A lot of that, by the time we get to the slide, you'll be like, yep, I've seen that, I know that. Okay? But it's all layered and repeated so that it really gets in well for you. And then reducing risk in your practice. How do you make sure that you stay, not only that you stay well, but that you keep the ability to practice, that you don't lose your practice to a malpractice suit, or to an illness or some other unfortunate situation, okay? And then how to manage accidents. If you don't see any accidents in your clinical training at your university, I can guarantee you'll see them once you get out in practice. Okay, so what do you do when there's an accident related to your practice of the medicine? How do you manage it? What's the proper response? What are your resources? Okay, so we'll get through all of that in the course of today. All right. So public health and safety is one of our key focuses here. In the 80s, as I mentioned earlier, there was really a lot of fear and a lot of finger pointing around HIV/AIDS, around hepatitis, and there was a lot of, shall I say, professional infighting, as well as medical doctors looked at us as less than, as poorly trained, as not knowing science. And we didn't always help ourselves. Sometimes we would be saying to a medical doctor, well, if you understood damn Pete and chi, you would know I'm doing the right thing. You know, well, doctors don't really understand Dan, Pete, and chi. What they need to know is, are you putting my patient at risk of getting hepatitis? Okay, so part of our obligation is not just to know that we're doing the job right, but also to actively promote the safety of the public. And then protecting your patients, your employees, and anyone who comes into your office. Okay, we're going to go through that a good deal of time. And public confidence in our profession. If you do your job right, which I know you will, your patients will come to understand that you have been highly trained, that your understanding rises in many cases to the level of their medical doctor's understanding of the topics that are within our scope of practice. Okay? And your patient's confidence in your knowledge, your understanding, and your skills will be high if your knowledge, understanding, and skills are high. So when your patient can honestly say, boy, do I trust Laraine. You know, when my patients are like, wow, Lorraine's the best, I really trust her. What happens is other people are drawn by that, and you get a practice that builds and builds from there, rather than constantly having to go out and advertise, I'm so good, okay? But a lot of that comes through your own confidence, your own skills, and then the way that you present yourself to medical doctors, to the nurses, to the home health care professionals you come in contact with, etc. So this course should help to really raise the standard of your professionalism, your confidence, and that deep-seated knowing that goes with your confidence into the world. Okay. All right, I've already covered this. The Centers for Disease Control, as you probably know, have the responsibility for looking at things like epidemic disease, looking at disease transmission, looking at treatment of disease, containment of disease, etc. Okay? They are so cool. and I have to say, I have a crush on several doctors at the CDC because they're really out in front working hard, and they work hard for us too. Never once when I've called the CDC have they said, oh, an acupuncturist is calling. You know, they've jumped right to whatever question I had. They're really out there for public health. OSHA was tasked, I think in the 60s or early 70s, to protect workers in the United States, okay? And that, you know, we're thinking, oh, factory workers, well, they're there to protect all workers, including the healthcare professions. So their job is to figure out how do we keep acupuncturists from getting bloodborne diseases by the way that their office is arranged, right? Or by the way that their tools are packaged or handled. So they study our workplace to make us safer, okay? So that's how they got involved in this picture. Excuse me. All right, so I've already gone through teaching and testing, training and evaluating. Now, who's going to look for your certification? When I got my certification, I was like, yay, cool. But nobody really cared except my school clinic. Okay, and then I graduated and found myself about 8 months after graduation treating my first patient in a hospital. You can bet that hospital was very interested to know whether I had this training or not. Okay, today what we have is your state licensing board is going to want it. Any school that you are attending or that you might eventually want to teach in is going to want to know that you've completed this course. Hospitals and medical clinics, as I said, will have this as part of your credentialing process. You know, they'll be like, okay, bring in your license, bring in your CNT certification, blah, blah, blah. And insurance companies. If your insurance company is anything like mine, you have to fill out an annual report on your practice, and it always includes, have you had up-to-date training in bloodborne pathogens? Okay. You'll find out today how to make sure that you keep your training up to date. All right, so we'll get to this page 5 any second now. Sorry, I skipped over a lot of slides earlier. You actually have a moral obligation to your patients. I know you already feel a professional and personal obligation to them, but you have that moral obligation that comes in the oath we take when we graduate, that is implicit in the oath that all medical practitioners live by, which is do no harm, which is to say actively protect as well as not choosing wrong action. Okay? Protecting your personal health and well-being. I can't stress enough how important it is to me that you top all of your efforts in your education with a career that is truly safe. 3 of my classmates from 1998 have passed away. And not because they got a needle stick, but because they didn't conserve their health. You know, they didn't take their own health seriously. So they didn't, somebody accused me of sort of blowing this up for the class purposes here, but they didn't die because of getting hepatitis B. They died because they didn't take care of themselves in the most essential ways. Okay? Part of a contemporary practitioner taking care of themselves is understanding the principles of clean practice from today forward. So we really want you to be healthy and able to practice for a long time. Legal and administrative sanctions we're going to get to in a moment. That can be astonishing and serious. And preventing harm to the profession. Okay? All it takes is one person to screw up on the big stage and the whole profession gets hit. Do you guys remember that dentist a couple of years ago who was in the news because he had been using infected tools and using infected solutions to quote sterilize his tools, and so had spread infection to 200 some patients? Okay, that hit the national news. It was a dentist in a small community in LA, but it hit the national news, and all of a sudden, everybody and their brother was looking down the dentist's neck and going, "What are you doing? Are you making people sick?" You know, just one person making mistakes, purposefully or otherwise, can really harm the whole profession. Okay, so there's an example of that. And before we get to that example, I just have a question. How many of you have $1 million? Okay, you don't want to admit it. Okay, how many of you, we'll go to something a little safer. How many of you have $10 million? Anybody? Okay, so we may have a millionaire or two in here, but nobody has 10, right? Anybody have $30 million? I still see no hands. All right, okay, well, this is what happens when you do something that hits the national news, okay? In Canada, a practitioner was alleged to have been, through poor practice, through poor skills, spreading Mycobacterium abscessus, okay, with non-sterile needles, all right? And those individuals in his practice, there were hundreds, but some of them got together and on behalf of everybody threw a lawsuit for $30 million. Okay, now this guy or woman, I don't know which it was, and I suppose it doesn't matter to us in the long run, was alleged to not only be using improper sterilization techniques, reusing disposable needles, but was also using a contaminated solution to store the needles. Okay, who stores needles in the alcohol that they're then going to use to swab the patient's body? Ugh. Using contaminated antiseptic to swab the skin. And there was every likelihood that this individual was potentially spreading hepatitis and HIV through their poor practice. Okay, so a group of patients got together and sued this individual for this and for the infections that they had documented. And guess what? Up until 2003, there had been no regulation of acupuncture in China. I mean, in Canada. Okay. Up until 2003, it was wonderful. I had colleagues who moved up there specifically because you could do cupping, you could do moxa, you could do bleeding, you could do the whole scope of practice, and nobody was looking over your shoulders to figure out, you know, whether that was legal or not, or define your scope of practice. So the profession was really flourishing in its good, hearty, full form until this event. When this happened, boom, the public got alarmed. If you know that the acupuncturist next door is making their patients sick, how do you know if your acupuncturist is making you sick, right? So alarm all over this province, and in fact in the governmental reaches across Canada, that then brought the whole force of regulation down on the profession, and then started the whole, you have to have a license, you have to go through, you know, our particular whatever in order to practice in Canada. So not only put a blot on the name of the profession, but also brought down a lot of regulation and lawmaking that hadn't been necessary up until that point. Okay, so don't be that person. All right. One of the most vulnerable times for you as a practitioner, according to your book, according to everything the CDC and OSHA can tell us, is when you're in training. That's when we make the majority of the simple mistakes that jeopardize our health. Okay, so during your clinical training, it's a time when you're most likely to make accidents happen, inadvertently or otherwise, okay? So just a couple of really quick glimpses into how this can happen. An intern, and these are true stories, an intern withdrew needles from a patient, was having difficulty with time management, so just sort of hurried and put the needles on a tissue on the shelf and covered them with another tissue. Okay? And then brought next patient in, more needles, more tissue, more needles, more tissue. When the next intern came in for their shift, the room was a mess. There were stacks of tissue on the counter. So the next intern cleans the table, grabs the tissues, and got, I forget whether it was 5 or 6 needle punctures. Sorry, my brain just went on vacation. Got 5 or 6 needle punctures from who knows which patient of the ones that the previous intern had seen. Okay, did those patients, had they been tested for hepatitis? Had they been tested for HIV? Was there any knowing which needle came from which patient? Okay, that intern that left those on the counter was suspended, and I don't really know whether that intern has ever gotten their license and begun practice. It's a very serious infraction, okay? The other individual had to go from multiple needle sticks straight to an emergency consultation with an infectious disease specialist, and then go through prophylactic care and retesting at the specific intervals that are designated here in your book for, I believe, a minimum of 6 months. Fortunately, that individual turned out not to have any long-term problems from that incident, but that was pretty fortunate. Okay. Another example, very quickly, a child playing in a treatment room in a large multi-practitioner practice. The child, while the mother was resting, the child had been in the clinic many times, while the mother was resting under her treatment, the child went around and gathered up all the needles that had been fallen behind the bed, under cabinets, etc., and was playing with them. Okay. Some of which were long needles, some of which were rusty and dusty from having been on the floor for prolonged periods of time. So when the practitioner came back in the room, here's this little 5-year-old playing with this stack of old, used needles. That could have cost that whole clinic everything they had right then and there. But the mom was amazingly practical and said, you know what? Johnny didn't hurt himself, because he would have cried if he did. He would have told me he stuck himself. So don't worry about it. Whew. Saved by a very practical mother. Many people wouldn't go there. Many people would just sue. Okay? So lots of food for thought on managing risks in your clinic. Yeah? All right, so now we go into page 5, Biomedical Risks of Infection. Okay. Before we get there, I'm going to have you look at, before we get to this information on the slide, I'm going to have you look at the immune system at the top of page 5. And the way that the immune system differentiates self from non-self. Okay? So when we are try to stick next to this microphone here. When we take in food, when we take in air, when we take in fluids, when we exchange kisses with others and embraces and sexual sharing, our body continually checks to see, is this new substance that's come in through the mouth or the nose or the eyes or ears or through sexual contact, or through the skin, is this me? Is this part of who I am? Or is it other? Okay? Is this saliva mine and carries everything that I'm familiar with? Or is this saliva carrying a pathogen from the food that I just ate? Do I need to generate protection against it? Okay? So the immune system is doing that automatically all day long, all night long, all the time. All right, so it knows how to generate antibodies to fight. It knows how to keep antigen levels appropriate to deal with threats. Sir, you might want to deal with your kit later and attend to the lecture now. Thank you. your body, the immune system does that through a very complicated progression of using all of your barriers to protect itself. So what are some of the barriers that we have that naturally greet the outside and tell it, this is me, this is not me? What are some of those things that we can come up with? Skin,
Mucus,
mucus,
cilia, cilia,
the cilia in your nose, yep, and ears, okay? Saliva, tears, okay, vaginal secretions in women, the acidity of those vaginal secretions is a defense, okay? And the mucous membranes of the body, whether it's the mouth, the anus, the vaginal tissues, etc. Okay, those are all barriers, natural barriers that hold the line for us against potential infection. We also have the differentiation of the humoral and cellular components of that in the middle of that first paragraph. So you may want to come back to that if that doesn't sound familiar to you from your studies. The immune system, humoral components are the constitutive complement protein system and immunoglobulins. So the body is constantly reviewing, how's our protein system doing in terms of our immunity, what immunoglobulins do we need to build, and those are found in the blood as well as in your tissues, okay? The cellular components are the ones that you've been studying how to look at on lab tests. Neutrophils, macrophages, monocytes, B cells, T cells, etc. Okay? Those are those active components that go up or down depending on how the body is doing in defending itself. Okay? So we've got the cellular and humoral components. And then we have those natural barriers, okay, that are interacting with those components all the time. So at the second to last paragraph, natural barriers, intact skin. Boy, is this important. I'm going to talk a lot about skin today because it's critical, okay? Mucous membranes of the nose, throat, urethra, rectum, stomach acid, okay, which kills many microbes by changing gastric pH, okay? Your respiratory mucosa, which is my weak point today, is having that fluids, that ability to generate fluids, protect the lungs, the throat, etc. from infection and invasion. Then you've got the epithelial skin layer, the mucous membranes we've already discussed, the cleansing effect of tears, urine, and vaginal secretions. So how do microbes get in? The final paragraph there on page 5. Through a break in the skin, a cut, a wound, a nick, a needle stick, okay, through an orifice. All right, so any agent can cause infection if it gets to the place in the body where it can grow, where it can multiply, where it can set up house and develop an army, okay? It also can get in and grow if it is of sufficient density and strength as a microbe, okay? And we'll talk about that a little bit more as we get into the various disease patterns. But if your body has gaps and spaces that are not well defended, or if the pathogen is strong, then it can get in and begin to multiply, proliferate, and create disease. Okay? So what are the things that bring that disease to these areas? Okay, in your office, we have things like the blood, the saliva, the sweat, the nasal secretions, other bodily excretions. We have dust, okay? Microbes love to ride on dust. They consider it their little Uber, you know, their little taxi ride to wherever they need to go. Microbes are in this room, swimming around and flying around on dust particles, even as we talk, okay? That's natural. And the reason we're not all flat on the floor sick is because we have intact immune systems. We have intact barriers, okay? But dust is always working, always busy bringing new populations to where they might be needed. Our clothing, our hair, our glasses, okay? In my clinic, it's a constant frustration to me to know when I am going to start needling instead of listening to the patient and taking notes, because I don't wear my glasses when I'm needling, but I do wear them when I'm taking notes. So putting them on and off in the middle of a treatment session means more times of cleaning my hands. Okay? So we look at all of these possible agents of communicating of disease, and we start to divide them up into two factors: autogenous infection and cross-infection. Okay? So infection is when a pathogen gets in, as we've discussed, and begins to create a disease state. And when that happens through an autogenous infection, and let me underline for a moment here, autogenous, if you look at auto or self, that's a big clue, a good way to remember that this is self-infection. This is infection from something that you are already carrying, okay? So autogenous infection tends to be the patient is already carrying that infection. The patient's already carrying that infection, and it just can get in and proliferate further when given opportunity. Okay? Cross-infection is when pathogens from another person or from the environment come into play. Okay? So you've all had the experience of being with a family member or a partner and saying, "Don't kiss me, you have a cold," right? Don't give me what you are carrying. Don't cross-infect me, is basically what you're saying, okay? So cross-infection comes either from somebody else through sharing of beverages, food, kissing, intimate contact, or from the environment, okay? So the environment is where we look at things like surfaces that may carry infection. When we look at wind, that may be a vector for viruses, et cetera, et cetera. That is cross-infection. Okay? All right, before we go any further, any questions? Because I'm going to start moving faster. Questions? Okay. So, our modes of transmission here, airborne. All right, if you are truly immune compromised, you're probably going to want to wear a mask if your immune system is just not functioning. Because what we do know is that when someone sneezes, pathogens from that sneeze travel at 200 miles an hour. How far, how wide, how long is this room? It's not a mile long, is it? Okay, so when somebody sneezes, the whole room has benefit of it in an instant, okay? Which means we know our immune systems are working because we're not all constantly sick, okay? Blood-borne pathogens, we're going to talk about quite a lot today, and about how blood-borne pathogens move. Infected fluids, as we've discussed. Oral fecal contamination becomes a big point, especially with some of the epidemic diseases. Skin contact. If your skin is not healthy, or the skin of a patient is not healthy, the skin of your bookkeeper sitting at your desk in contact with the surfaces that you contact all day long, if their skin is not intact, they may be vulnerable. Or contact with infected wounds. All right, we'll talk about handling those risks as we go. So types of infecting agents. We're going to specifically talk about viruses today, hepatitis viruses. We'll go through a bit of the alphabet there. We're going to talk about HIV. Influenza is mentioned, and it rises and falls in our attention every year, depending on the strain of the flu, where it's coming from, the severity of it. It's not well discussed in this course at this time, okay? So we know that influenza is a major pathogen that we can protect against by our basic protective strategies, but we're not going to go into the disease mechanisms of the flu today, okay? And then we are going to look at bacteria such as MRSA, okay, and discuss how that's communicated and how we can deal with it in clinical practice, okay? Also of concern today is tuberculosis, and in particular antibiotic-resistant tuberculosis, which is on the rise. It's come back to American cities in many cases, and it is something that you need to be alert to and trained in. It's mentioned in this course. We don't go through it as thoroughly as probably we will do at some future point, but it is something to keep in mind and to know the appropriate protections for it, okay? All right, so we've spoken already about these natural barriers, keeping them intact. We're going to move right into hepatitis A. All right, you're going to follow along in your book for pages 7 and 8. And we'll talk about viral load and that sort of thing when we get to hepatitis B, for those of you who are wondering why we skipped over it there. All right, hepatitis A, infectious hepatitis or short incubation hepatitis. This is most common in areas where there's a lot of people, whether that be a cafeteria or an elder residence or a kindergarten, elementary school, something like that. And the mode of transmission of hepatitis A is primarily oral fecal, that is to say, one of the school workers or one of the cafeteria line people goes to the bathroom, fails to wash their hands, then returns to work preparing food or dealing with individuals in their facility, and feces from their hands get communicated either to the food and therefore into the mouth of others, or potentially simply onto others' hands, into their mouths, etc. Another way that we see this is with children, small children who are still in diapers, or elders who may be incontinent, who may have either loss of capacity or not yet gained the capacity to realize they shouldn't place their hands in their mouth after they've been, adjusting their dirty diaper or whatever. So oral fecal contamination is the main way in which this gets into the population. And it's usually epidemic. You'll usually see 20 little toddlers or kindergartners or first graders all coming home bright yellow from having contracted hepatitis A from somebody contaminating the food supply in the school, or you'll occasionally see an epidemic through a cafeteria in the community or a restaurant, etc. But the incubation period is 2 weeks to almost 2 months, so 15 to 50 days. And the incubation period means what? Anybody know what the incubation period indicates?
Time it takes for the virus to actually mature and to show these signs.
Okay, all right, thank you for your speaking up there. Yeah, a virus gets into the body, sets off to grow, and you do not know that you are ill while it is growing and replicating. And in this case, it takes about 2 weeks for the earliest cases to show up, and sometimes 2 months for the trailing edge of those who've been exposed to become infected and manifest disease symptoms. Okay, so this incubation period is when the pathogen is developing its resources, developing its numbers, and becoming substantial enough to cause the infection. All right, with hepatitis A, what we know is that we get abrupt onset. Okay, so we get abdominal discomfort. You know, you have little kids coming home and going, "Mommy, my tummy hurts." Or you have elders who have lost their appetite and are uncomfortable because of abdominal discomfort, nausea, loss of appetite, fatigue, dark urine, and jaundice. So the main way we often find out that there's an epidemic of hepatitis A going around is, like I said, when everybody starts turning yellow and somebody wonders what happened here, and then traces it back in the last 2 months to or 2 weeks. So most of the times the symptoms don't last more than 2 months. There is an effective vaccine, and school children increasingly are vaccinated. Infants are vaccinated against hepatitis A. So the incidence of it in the general population has been on the decline. But do you, as a healthcare worker, need to take that vaccine? So can I see a show of hands? How many of you think you should take the hepatitis A vaccine? Lots of people sleeping or disagreeing. Okay, how many people think you should not take the hepatitis A vaccine? Oh, there's lots of people sleeping or not wanting to answer. Okay, most of the time, by the time you reach your ripe old age, you've already been exposed to hepatitis A. Okay, or for some of you who are quite young, you had the hepatitis A vaccination at some point in your youth and are already protected. Okay, so do you as a healthcare practitioner need to launch off and get this vaccine to protect you in practice? No. Okay, because if we tested everybody in the room, most of you would have developed the appropriate antibodies at some stage in your life to protect you from this disease process. Okay. Now, is there a chronic state of this disease? Not really, although what we do know is that about 15% of the people who are infected can get a relapsing case of it. So they'll get better, and then they'll get worse, and they'll get better, get worse. And that stage can go up to 6 to 9 months for those unfortunate individuals. Okay? So I'm going to launch through the rest of the hepatitises, and then I'll give time for questions. So if there's something that strikes you about any of these, jot it down in the margin so that you can definitely ask that question once I finish this segment. All right, hepatitis B. Now, I want you to notice an interesting thing about the way this is presented. What's the largest part of the graphics on this page?
The heading,
Yeah? What does the heading say?
major risk for acupuncture.
Okay, I just really need to underline that. Okay? If there's any one thing that I need you to be aware of as you go out to practice, it is that if you are not alert and informed and aware of hepatitis B, this is one of the greatest risks to your health going forward. Okay? If you are not practicing clean needle technique, if you are not recognizing in your patients the symptoms of hepatitis B, this is by far the greatest risk in the public health in the United States at this point in time. Okay? So it's called serum hepatitis. That is to say, we can find it in your blood. Okay? Or long incubation hepatitis. Now, long incubation because it takes 2 to 6 months before you know you have it after you've been exposed. Okay? So why is this important? I was talking with a colleague recently who said they're seeing 14 patients every day, you know, which is a real nice number. 14 patients a day, 5 days a week. That's a real nice number of people coming in. that means also that you have 14 opportunities every single day to encounter hepatitis B. Okay? It does not stop just because your practice is rolling. Your patients will come in knowing they have it, or not knowing they have it, or a long-time patient will come in newly exposed. And it takes 2 to 6 months to know whether you've developed the disease. So, needle stick with a patient B, March 3rd. Oh, good patient, really cool patient, healthy, very health-oriented. Yeah, they're fine. Okay, March 3rd, needle stick. Oh, it's fine. I went to an infectious disease specialist. He said, everything's fine. Then that patient comes in April and says, I'm a little embarrassed. I didn't want to tell you this, but in February I had several affairs. The clock has to go back to that needle stick. Were you exposed or were you not? Was the patient infected at that point or were they not? Okay, so this is where it becomes really important. So incubation period, 2 months, 50 days, is a little short of 2 months, but 2 months to 6 months, 50 to 180 days, in which that individual may be sharing what they've contracted, okay, without knowing that they've contracted it, in which you may be exposed to it if you're not alert to the disease mechanisms and patterns, okay? So notice this treatment in the middle that I've been ignoring so far here. Treatment, HBV immunoglobulin immediately after exposure. It's very effective immediately after exposure. But if you don't develop the disease for 2 to 6 months, how can you get this treatment after exposure? Okay? This is why you really need to know this disease very well to know whether or not you've been exposed. Okay? Mild flu-like symptoms and signs. How many of you have had a day in the last year where you're like, you know what? I'm not going to class today. I just don't feel well. Anybody? Yeah, most of us. At some point in the last year or two, a day where it's just like, I just don't feel good. I'm going to stay home. I'm going to take care of myself. All right? So mild flu-like signs and symptoms. I'm not saying you have hepatitis B because you had those mild symptoms, but that's one of the hallmarks of hepatitis B. It's very mild symptoms initially. Only 60% of the individuals who contracted have fever. Okay? Malaise, not feeling well. Gee, 2 weeks ago I had a day where I just didn't feel well all day. I told everybody, go away and leave me alone. Okay? Does that mean I have hepatitis B? How do we figure this out? Loss of appetite and nausea. Okay? Abdominal pain, diarrhea. And then the clinchers. Okay, what's the difference between food poisoning, where you get abdominal pain, diarrhea, don't feel good, don't want to eat, and hepatitis B? Chills, rash, very distinctive rash. For all of these images that you want through the day, where I say a rash or a sore or something like that, when you get home, Google Images is great on showing you a hepatitis B rash or whatever others we come into contact today. Okay? Joint pain. So when somebody comes to you and goes, gee, doc, I just don't know. My joints ache, I've got this weird rash. Your first guess is not spider bite. Thank you. Your first guess is what's been going on in this patient's life in the last 6 or 7 months. What sort of exposures have they had? What other symptoms do they have that might fit this hepatitis pattern? And knowing then how to say, let's get a blood test to make sure what's going on. Okay? So that you can take this constellation that includes chills, rash, joint pain along with everything else, and make a informed decision to pursue testing for that individual. Okay? All right, so when we look further at hepatitis B, we see a pretty grim picture in terms of how it affects people. All right, so for infants, 90% of babies who are exposed to hepatitis B contract it and become chronic carriers of it. All right, and that means for life. That means for life. I had a patient who came to me recently in his late 30s, and unfortunately, one of the most sad and bitter people I've met, and was very honest at the outset, said, I have hepatitis B. And I said, when did you get it? And he said, it was a gift from my mother when I was born. You know, he lived his entire life with this illness because as an infant he had no immune defenses from it. Okay? Children from 1 to 5 years of age can shake it off sometimes with appropriate care and support, but 30% of them become chronic carriers. Okay? So we see it's only once you become an adult, 5 years and over, that the rate declines somewhat in chronicity, and we see in the adult population about 1 in 10 individuals becomes a chronic carrier of HIV. Okay? I mean HBV, pardon me. All right, so how do we test this? When your patients come to you and they've already been tested, they'll present test results to you, or you can send out for tests. Depending on the stage and the factors, you can get an antibody titer to test your immunity. So perhaps you had the hepatitis B vaccination at some point earlier in your life. You can go in and get them to test your antibodies to see if you still have high protection. Okay, it used to be thought that hepatitis B vaccination was one and done. Now we know that it is one and test to see whether the body has developed sufficient antibodies, and test again at a later date to see whether it's maintaining that immunity. Okay? For somebody who is uncertain whether they have the disease or whether they have a progressive case of the disease or whether they've developed immunity, then doing blood tests, serologic tests for antigens in the disease process can be very helpful and can tell you where they're at. Okay? And in any event, the CDC says that you as a healthcare worker should be vaccinated. Now what we've seen is that in the years since the CDC came out with this, since we began implementing these guidelines, that the incidence of hepatitis B has declined in the general population. It was quite high in the 70s, early 80s, and what we've seen is that it has declined in the general population, quite likely attributable to higher training levels in all of the medical professions and to the use of vaccinations. Okay, so about the vaccinations on page 10, you'll want to know that your immune response in that second paragraph there is important. You may need one or you may need a second series of vaccination, and you may be one of the individuals who is a non-responder. Now, this should be offered to you or required of you, depending on your school. They will either offer you the hepatitis B vaccination, or they will require you to show that you've had vaccination prior to beginning your clinical training. If you're already in your clinical training and your school hasn't mentioned this, go back to the clinic manager and insist that they pay attention to you. I'm sure your schools are doing fine on this, but you should have been either offered the vaccination or asked to show that you've been vaccinated. If you have reasons for which you would not do well with the vaccination, some individuals have health issues which an infectious disease specialist would say, oh yeah, don't do that vaccination right now. If that's the case, then you'll need simply to demonstrate for your school that you've been offered or requested to have the vaccination, but that you were not able to do so at this time. Okay? But that's one of the most important steps, because when are we most vulnerable in our practice of our medicine?
In training.
In training. Good. Somebody spoke up. Yay. We're most vulnerable in this first year of clinical training, right? So that's the time when you should already be protected against this. If you're not, take it up with your clinic director now to make sure that you are appropriately protected. Okay. Now, as far as the serologic tests for antigens, that comes into play as the disease rises and falls. Okay, and there is, sorry, I normally track this a little bit better with better light, but there is a point at which your antigens, page 9, middle of page 9, where you're looking at transmission in the healthcare setting, like a needle stick or a cut from an infected instrument, okay, or a contaminated instrument. So that is a pretty small risk, only like a 6 to 30% risk in that setting, especially with acupuncture needles, okay. So the risk is pretty small. However, it's higher if the hepatitis B antigen status of the individual that was the source of the contaminated blood or body fluids is at a particular level of being antigen positive. So when you have an individual whose serologic tests for antigens shows that they have higher surface antigen in the hepatitis B process, that means they have a more dense, more aggressive stage of the disease, and it would be even more important to attend to appropriate prophylactic care or that sort of thing if you are in a needle stick situation. An infectious disease specialist can advise you on this at that point, okay? So just to make one statement about that, when you I usually teach in a room that has a whiteboard right behind me. When you are working with with the possibility of being contaminated, you want to go not just to an emergency, family doctor, or not just to your clinic director, but if there's a possibility that you've been infected through a needle stick, you want to go to an infectious disease specialist. Okay, somebody who actually pays attention on a regular basis to how these diseases behave. Okay, you don't want your family medical doctor just patting you on the shoulder and saying, "Oh, it was just an acupuncture needle and it was just in your thumbnail. Oh, no big deal." Okay, you actually want somebody who really understands these disease processes to advise you on what's appropriate. Okay, so as an employer, when you set up your practice, as soon as you hire anybody else, whether it's an acupuncturist, a receptionist, anybody who comes in and out of your office in contact with your treatment rooms and the materials in them, etc., as soon as you hire them, you need to offer them hepatitis B vaccination to protect them also against the risks in working in your office. Okay. All right, moving forward. Hepatitis C used to be called non-A, non-B. That's still one way to distinguish it, but there are more letters in the alphabet now. So we commonly call it C. It is the most common chronic blood-borne pathogen. I know you can read. I know you don't need me to underline it, but guess what? I'm going to. It's the most common chronic blood-borne pathogen. Just in case that happens to show up on a test somewhere, you might want to know it is the most common chronic blood-borne pathogen. Okay? And there's a high incidence of the chronic state. People who get hepatitis C, they're at high risk of becoming chronic carriers of it. Okay? And beyond that, it's the leading cause of liver disease in the United States today, and the leading cause of fulminating progressive liver disease, costing lives. Okay? So you get it through exposure to blood or blood products, to a lesser extent through sexual transmission. So exposure to blood, how many people come into your practice having had surgery where they had to have a transfusion? Okay? For some period of time, hepatitis C was not effectively filtered out of and tested for in our general blood supply, in our emergency blood supply. So you'll have 40-year-old housewives coming into your practice and saying, I just discovered I have hepatitis C. And their husband is wondering where they picked this up, and they're terrified of how they got this disease. Well, it turns out, what happened 5 years ago? I had an emergency C-section, lost a lot of blood, got a transfusion. Okay? So there are people, and 5 years is probably a little too recent. We've been screening a lot more effectively in recent years, but it was actively in the general blood supply because we weren't screening it out, screening donors for it for a long period of time. The other people who will be coming in, besides people who've had transfusions, are hemophiliacs who are reliant at times on transfusions for survival. They were greatly affected as well by hepatitis C in the general blood supply. So it is the most common form of transfusion hepatitis. The incubation period is right in the middle of the other guys. Okay, hepatitis A, 2 weeks to 2 months. Hepatitis B, 6 weeks to 2 to 6 months. Okay, and hepatitis C is right in the middle, 20 to 90 days. So almost 3 weeks to almost 3 months. Okay, 20 to 90 day incubation period. Like hepatitis B, to a certain degree, it's an insidious onset. Insidious means sneaky or not that noticeable, kind of coming in under the radar. Okay? So insidious onset, anorexia, nausea, vomiting, jaundice. Okay? Anybody can lose their appetite for a day, throw up, feel nauseous. But when you notice the jaundice, time to pay attention. Okay? About half of these patients develop a chronic hepatitis, and a good number of those progress to cirrhosis and progressive liver disease from there, including liver cancer. Okay? There is no good vaccine for hepatitis C. The good news is that there are increasingly effective treatments for it, and there's very, very good results from collaborative care, from you working from your side of things, and the medical doctor working from their side of things, providing high levels of collaborative care. About 3 or 4 years ago, one of my Hep C patients called me and said, I'm cured. And I said, no, you're not. There's no cure for hepatitis C. And he goes, no, I'm cured. I was like, why do you say this? I figured I just wouldn't keep going back and forth with him all day. Why are you saying you're cured? My doctor says there is no hepatitis C in my blood. Okay? That was the first time I ever heard of a cure. And the guy is fortunately, happily still healthy and has no evidence of hepatitis C in his blood. And increasingly we're finding with appropriate care, and especially with collaborative care, where we're both doing what we do best to support that patient, that recovery is possible. But it's still not something to take lightly, okay? It's a very serious disease with very serious consequences. Hepatitis D, okay? C, if we think of chronic, okay? D, if we think of defective. Hepatitis D is a weak little virus that is like the shadow of the bully on the playground, okay? Hepatitis B is the bully, the big guns that makes everybody sick really easily. Hepatitis D hangs out with B and takes advantage of the doors that B opens, okay? So D requires B to be there or it can't make you sick, okay? So if you don't have hepatitis B, hepatitis D can try all day long to make you sick and it won't succeed, okay? It's defective. It only works when its bully buddy B is there to activate it, okay? It's known as delta hepatitis. It's most frequently found in the population that you would expect that already have B. So injection drug users, hemophiliacs, those individuals with high risk lives already, okay? There is no vaccine, but how do you prevent D from getting in? Oh, come on, you guys. Okay, don't get B, and how else do you prevent D from getting in? Come on, you guys. If you're vaccinated against B and you have immunity against B, you can't get D, right? Okay, so we don't need a vaccine against D because it's not going to get in and get active unless B is already there, okay? So, does that make sense? Okay. E for epidemic, all right? B for bully, C for chronic, D for defective, E for epidemic. Hepatitis E we used to teach that this would only affect outbreaks in developing countries where the water supply and the public utilities were not up to snuff. So it used to be assumed that if you didn't have appropriate plumbing in your house and that sort of thing, that you might be more vulnerable to it, or that the water supply would be contaminated and not cleaned, etc. What we find now is that outbreaks in the United States are linked to fecal contamination of the water supply. So if the water treatment plant goes under, then that can be a cause for concern. But there's also the potential of seeing it in situations such as Superstorm Sandy, where many communities had their public utilities literally flooded out of existence. Okay, at that point, the water supply becomes insecure, and the possibility for an epidemic of hepatitis E comes in. Now, why are we concerned for that? Because it usually is mild in the general population under those circumstances. However, who is it really dangerous to? Pregnant women, thank you. All right. It is really severe in some individuals. It can be lethal in pregnant women. Okay? So in a situation where there is a compromise to the water supply, where the general public in 2 weeks to 2 months following this compromise begins to manifest these symptoms, then what we know is really time to protect the women who are pregnant. You know, time to make sure that they know to only use appropriate water that's been appropriately filtered and protected from contamination. Okay, not that we don't protect the whole population, because it can be severely disabling in some individuals, but pregnant women in particular are at risk when there's an epidemic of E. Okay. So how often do we see it in the United States? Not that often. Is it increasingly a possibility with global warming, superstorms, and that sort of thing? Yeah, it is. So don't neglect it just because it has developing countries attached to it. Periodically, parts of our country become developing countries all over again. Okay. So incubation period, 2 weeks to 2 months, 15 to 60 days. Sudden onset, fever, malaise, nausea, anorexia, no vaccine. So when you're a chronic carrier of hepatitis, and by the way, please don't let your patient define for you whether they are a chronic carrier or not, okay? Individuals who have hepatitis may have had the experience of having had a previous healthcare professional say, I won't treat you or go elsewhere, or they may fear being stigmatized because they have hepatitis B or have had hepatitis B or any of the other hepatitises. So they may walk in and go, oh, I had hepatitis, but I'm fine. Or they may not disclose their hepatitis state until they think they can trust you not to send them away. You know, don't play games with it. Know these patterns well. And when a patient says, I had hepatitis, what's your next question?
How long ago?
Not how long ago. What's the next question?
Blood test.
Okay. When was your most recent blood test? What were the results on your most recent blood test? Oh, I don't know. I haven't been tested in 5 or 10 years. Okay, well, I think it's time for a retest. Okay, so that you actually know for sure what their status is. Do they have antigens? Do they have antibodies? Do they have an active disease process with high antigens? Or are they actually in recovery as they claim? Okay. All right. So if you are a carrier, you're continuing to shed the hepatitis virus through bodily fluids and excretions. So if you're shedding that virus, who can get it?
Anyone who touches your body fluids.
Anyone who's-
Yeah, anybody who comes in contact with your body fluids or excretions. So anybody you share a bathroom with, anybody you share a kitchen with, anybody you share a bed with or a family with, okay? So we need to be alert to individual status and to helping them manage, such as with hepatitis B, isolating their shaving implements, their toothbrush, their utensils for eating, etc. And that's detailed in the book here. So, but a chronic persistent carrier, somebody who persistently has a chronic state of disease, okay? They can infect others even though they may not have symptoms, okay? So somebody may come into your office looking perfectly healthy and say, I have hepatitis B, and you'll be like, oh, I can't believe that. You're not jaundiced, you look great. And they can still infect others. And the most responsible position is for them to be very clear on that, okay? A chronic active carrier is a little different in that they can still infect others, but guess what? They are still getting sicker. The disease process is still progressing. So a persistent carrier is just someone who can infect others and persists, usually against their will, in being infectious with the disease. But a chronic progressive carrier of this disease is somebody who is actually getting worse, okay? And we want to be alert to that because the damage to the liver proceeds and things get more lethal as we go. All right, so a summary of hepatitis viruses. This is your great friend, this chart. All right, you want to be alert to the patterns of transmission to the patterns of onset, to whether there's a vaccine or not. You want to be alert to the incubation period. All right? So incubation period, the longest is B. So it's the sneakiest, creepiest one, because while you are developing the disease, you can be infecting others, and you may be doing so for up to 6 months, right? Okay. The shortest incubation periods are A and then E. Okay? And those are the epidemics that we recognize the most rapidly, naturally, and that have generally the same cause. So with B and C and D, the cause can be a community-based cause, such as a community of drug users or a community of hemophiliacs. But with A and E, we know, oh, all of these people go to the same facility for care or for food. Or with E, all of these people are in a community in which the water supply safety has been compromised. Okay? All right. Is this helping to clarify these a little bit as we go through these again? All right. Transmission, fecal oral, A and E. Again, the shortest incubation period. So the time from the hand to the mouth, a short period of time, short period of incubation for the disease. The bloodborne ones, longer period of incubation for B by far, and a reasonably long window for C, up to 3 months of incubation period for C. Okay, again, the shorter ones, abrupt onset, A and E, very abrupt. And the sneaky ones, the bad ones, B and C. Okay. The vaccine status, the first two have a vaccine, the others don't. Which one does it not matter at all whether you have a vaccine or not?
D.
D. And what's the controlling factor? The presence of B. Okay? If the individual is immune to B and has not got hepatitis B, they can't get D. Okay? Chronic state. Notice in these guys that have the shortest incubation period, it's also usually the shortest disease state. Boom, you got it, you're done. Okay, unless you develop one of the relapsing cases in A, or unless you have one of the more lethal responses to E. Otherwise, everybody pretty much gets it, gets over it, no chronic state. But for B, the chronic state depends on age group. Who is the most susceptible with B?
Children?
Infants. Okay? The population that develops chronicity in 1 in 10, okay, older than 5. Okay? Hepatitis B, if you're over 5 years old, the likelihood is that only 1 in 10 individuals will develop chronic disease. Okay, so we're going to loop back around again. What about C? Who develops chronic disease with C?
The largest person.
Okay, some of you can't see the board, sorry. 60 to 70% of those infected with C may develop chronic disease. Okay, all right. Question. Which of the hepatitis viruses that we've gone through has the longest incubation period? B. And how long is that? Okay. So how many months might that be?
6.
Okay, thank you. All right, so let's go back for just a moment to a couple of statistics I want to dwell on a little further. Okay. Density of infectious agents on page 6. One of the reasons that B is so very successful is because it is a highly dense infectious agent. Okay? So if you imagine B as being this sentence here in the middle of the page, it's very dense. There's lots of information, there's lots of letters, there's lots of soldiers in that army for hepatitis B, okay? But if we go to another disease pattern that is not so dense, that is not so well armed, let's say it's just the word question, okay? Represents the density of pathogen for HIV. Okay? This has a lot to do with how prevalent the pathogen can be in the environment, in the blood supply, and in communication. When you have a highly dense pathogen that is well armed and ready to roll, the likelihood of infection is greater. Okay? So, one of my patients some years ago was that scenario of coming in several months after beginning treatment and saying, I'm really embarrassed to tell you this, but now I'm worried. My husband went on a business trip and I was mad at him, and I had 3 one-night stands. Okay, well, who knows what made this woman, just kind of go on a revenge trip, but she had no idea who the men were. She had no idea what their health status was. And she was starting to be really fearful that she may have contracted something. But it had been several months, and now she was really fearful that she had shared that with her husband. Okay? Well, if one of those individuals had HIV, and she had had limited contact with them, the likelihood of her contracting disease from them was lesser in terms of the density of that virus and its capacity to infect than a contact with saliva, blood, or body fluids from someone infected with hepatitis B. Okay? Now, I'm not saying you should go sleep with just whoever and go, it doesn't matter, they don't have a dense pathogen. But when we start looking at the density of pathogens, as discussed there on page 6, is when we start looking at how pathogens really get in there and get the job done. It's why we look at a globule of hepatitis B on the table, on your treatment table, on the counter in your office, on the counter where people pay their fees to see you. Okay? A globule of hepatitis B on that countertop, how long can it persist there? Somebody read the book? Yeah. How long can it persist on that countertop?
10 days.
10 days? Anybody got this statistic in their book? It's a long time. Okay? All right. For the same globule that is infected with HIV, how long is that globule hanging out on your countertop, on a tabletop, on your treatment table? How long can that infect someone?
Not too long.
Seconds or minutes, because it's a very low density virus. It relies heavily on the host organism to protect it and give it an environment to live in. Okay? So it takes exchange of blood, well, I shouldn't say exchange, but it takes sharing of blood or body fluids on a very intimate level for HIV to be able to jump that gap. Whereas hepatitis B can jump that gap simply by sitting on a tabletop and waiting, right? Make you think you might want to clean your office on a regular basis? Yeah. All right, let's move on. Before we do though, any questions on hepatitis B, C, D, E, A? I know somebody's got a question. No? Okay. you can save it up and bring it up later, okay? I want, though, to look at one more thing about hepatitis B on page 11, where we've been talking about children and that sort of thing. 70% of the people, in the second paragraph there, 70% of the people who've recovered from the symptomatic stage of the disease are still infectious for 3 months or more after symptoms have subsided. Okay, so as you work with your patients, and you will have hepatitis B patients, you will be coaching, educating, and training them to understand how long their infectious state may persist and how long they may be sharing the disease with friends, family members, etc. Okay? All right. On page 14, there's a nice little statement here which I had already expressed, which says, since 1984, guidelines for presenting the transmission of hepatitis have resulted in the incidence of hepatitis B through acupuncture transmission dramatically decreasing. Okay? Just to underline that, dramatically decreasing. It doesn't mean it has completely stopped. So your clean technique is vital. What we're learning today about how not to transmit this disease is really of great importance to you. All right, let's move ahead to page 17. Human immunodeficiency virus. We know that there's 2 types of this virus afoot in the world. Type 1, if you're looking at the top of page 17, HIV-1 is the more rapidly infectious, tends to be initially the harsher disease. Type 2 is a little deceptive. It's slower, milder, and it seems initially to be less infectious, but as you go on, HIV-2 catches up in its disease. As the disease matures, it becomes just as infectious as HIV type 1. Okay, so know that type 2 initially is milder, less infectious, contagious, but as the disease matures, it becomes more infectious in that individual. Okay, at the moment, HIV-1 is still the most virulent and still the most easily transmitted initially, and it's still the cause of most of the infections around the world. Okay, so when we look on page 17 in that second paragraph there, when we look at the risk of infection, I'm becoming tongue-tied. My break is going to be coming any minute now. The risk of infection from exposure to contaminated blood is 30% for an HPV-contaminated hollow bore needle stick, as opposed to 0.3% for HIV under the same conditions. Now, why am I reading from your book word for word? Because this is a very important fact for you to know. Okay? It may even show up, who knows, in an exam or in your clinic in the future. Okay? The risk of infection from exposure to contaminated blood is 30% for an HPV-contaminated hollow bore needle stick, as opposed to what? 0.3%. What is that, 100 times less? Mathematicians? Yeah, 100 times less. Okay? So, universal precautions, if you have intact skin, if you're observing universal precautions, which for our profession doesn't mean a cold room with full body armor and that sort of thing, but it does mean, when appropriate, wearing gowns, wearing gloves, using eye protection. Universal precautions can almost completely prevent the risk to you of getting HIV in the clinical setting. Okay? What we know about HIV is, and one of the things that we that brings it to our attention for individuals, is when the CD4 lymphocytes begin to decline. Okay? When we see that happen, we begin thinking, uh-oh, we should test for the presence of HIV. Okay? The reason HIV is as dangerous as it is not because of HIV itself. If you look at the death certificate of individuals who have lived with HIV, the death certificate almost never says that they died of HIV. They die of the things that HIV lets in by decreasing immune function. Okay? So the loss of these lymphocytes and the protective functions that they play is one of the clues to us that the individual may have been exposed. Okay? The transmission of HIV, as you would expect, is through very intimate contact, because remember, it's a very low density virus. So there has to be very intimate contact in order for the virus to be transmitted. Okay? Through blood, through sexual contact, through prenatal communication, and through breast milk. Okay? So, will I get HIV by hugging my patients? Will I get HIV if one of my patients comes running in, has really good news, gives me a great big sweaty hug and a kiss? Most likely not. Okay? Because the disease is not powerful enough usually to make the leap without very intimate contact. Okay? So there's very low risk of transmission between patients and healthcare workers. And there's very low risk of transmission from office surfaces, unless there's a large quantity of what? Blood. Okay? So would you want necessarily to do very, very aggressive bleeding techniques on an individual with HIV? Most likely not. Or if you do, you're going to use universal precautions. Okay? And unfortunately, in the state of California, you're not going to be doing bleeding techniques on them anyway, because somebody put up a very irresponsible video showing quite aggressive bleeding, and it brought down the attention of all of the regulatory agencies. So we are not doing bleeding in the state of California right now. All right? But back to HIV. When a patient comes into your office with HIV, you're going to want to ask them their history. Or if you suspect a patient has HIV, you're going to want to ask them their history, because we don't know what the transmission period is, or what do you call it? The incubation period is. It's long. There are some individuals that were undoubtedly exposed in the 80s who are still relatively healthy. Okay? There are other individuals that were exposed in the 80s and became sick, gained opportunistic infections, and died very rapidly. We don't really know yet all that contributes to the progression of HIV as a disease, or to how long an individual's immune system can coexist with a developing disease. Okay? We just don't know. So once the infection is clear, though, as the immune function declines and the infection becomes obvious in the body, what we do know is that there can be this very long progression from the disease to the acquired immunity status of AIDS. Okay? So someone can be HIV positive for quite a long time before actually developing full-blown acquired immune deficiency syndrome. Okay? As I've stated, it leads to opportunistic infections, various kinds of pneumonia. I am not thinking of those other opportunistic infections right now, but cancers, Kaposi's sarcoma, etc. So, as I said, most of the time, what takes a person off this planet is not the HIV. It's the other bullies that it has opened the door for. Okay? There is no cure for HIV. There's not currently a recognized universal vaccine for HIV. It's the focus of, as you know, tremendous amounts of research, and there's a development of an understanding in Western circles of using, similar to the way we use herbs together to balance and defend an individual. The Western community is beginning to use multiple substances in cocktails of treatment patterns for people with HIV to prolong their health. And we know that medications slow progression. There are some cases in which individuals are stated to have zero presence of HIV in their blood at this time, but it's not yet been stated that there is a reliable state of cure for this disease. So even though it is not the fiercest disease that you will come in contact with in terms of risk for yourself in clinical practice, it is still a clinical reality that you will be working with these individuals, some of them for very long periods of time. Okay. All right, so you're at page 19, you want to be asking them, have you had exposure to blood products or blood? You know, have you had a blood transfusion? Were you a medic in Afghanistan or Iraq? What are the things that might have led you into contact with this? Have you had a risky lifestyle? What drugs have you used in the past 10 years? Okay. What is your sexual history? How many sex partners have you had in the last 2 years? Now, that question may not cover the whole territory. There may be somebody who's been faithfully married for 5 years and had 15 sex partners before they married. Okay, so you want to elicit the information diplomatically, but you want to be clear with the individual about their history and their risk of exposure. Okay, and you do need to ask about drug use for everybody. Okay, even the mom who brings her little 2- and 3-year-old into your office and looks so cute and healthy, she may well have been a drug user in her 20s before she changed her life pattern and got into a family. You know, I hesitantly asked this gorgeous businessman. He had like 3-piece suits. He had been a trader on Wall Street, very successful businessman in his early 60s. And I very hesitantly said, did you ever do any drugs? Thinking I would offend him because he looked very straight-laced. And he goes, oh, honey, I did every drug in the book. Okay. At that point, it was like, oh, well, did you ever have illicit? Yes, I had many partners back when I was young and stupid. You know, well, that counts. Okay. So don't let your patient's current appearance or lifestyle dissuade you from asking these very important questions of them. Okay. All right. Any questions on HIV before we move forward? What questions come up? All right. Methicillin-resistant Staphylococcus aureus, otherwise known as MRSA. Okay. The key thing about MRSA is prevention, protection. Okay? It is a gram-positive bacteria, which is to say if you put some of the bacteria on a slide and put it under a microscope and stain it, it will change color quite beautifully to let you know its status as a gram-positive bacteria. It's associated with wounds and medical infections. It is an antibiotic-resistant infection, and it's spread by skin-to-skin contact. Okay? It's very prevalent in hospitals, in medical settings, in clinics, and I would wager $100 that I could come to any clinic of any university of TCM in the country and find MRSA in the waiting room or in the treatment rooms. Okay? It is very prevalent, and we have to protect against its transmission because it's a wicked, nasty infection. Okay? Once it gets into a family or a community, it tends to circulate. Okay? It's highly resistant to antibiotics. And in the cases that I have had, when I referred them to their medical doctor for care, they were sent to urgent care, and in a couple of cases they had surgical excision of the wound to remove the pathogen. Okay? So never think that in your clinic you can treat MRSA by yourself. Okay? When you spot a MRSA lesion, which has a very distinctive pattern, then you want to immediately send that individual to urgent care for medical care. Now, can they come back to you while they have MRSA? Of course they can. But they're going to want that wound to be covered, protected. You want to clean all surfaces that they've come in contact with as they've entered your clinic and gone through care. And you want to coach them on cleaning in their home environment. Okay? I had a little 5-year-old who I was treating for asthma, and his mother and the whole family would come in every time. My waiting room would be teeming with this family, up to 7 individuals just hanging out in the waiting room while this 5-year-old got treated. And the mother came in one day and said, would you look at my, and she pulled her waistband down to show me the back of her hip, and she had a big MRSA lesion on her hip. I sent her immediately for medical care. They excised the lesion. 2 weeks later, the daughter in the family goes, "Oh, Dr. Laraine, would you look at my leg?" She had a MRSA lesion on her leg. It went through the entire family, because no matter how many times I said to them, you need to take these measures in their environment, it had gotten into their environment. So it went from one family member to the next to the next. It does that aggressively in hospitals and in clinics. So unless you want your patients to be coming back to you saying, "Thanks a lot, doc, I got MRSA from your clinic," you want to learn how to care for the surfaces in your office and for any individuals who come in with infected lesions, so that it doesn't become a feature of what you share with your patients as they come for care. Okay? That's also why you want your skin to be healthy and intact. You don't want to pick it up from your patients, even if you are really cautious and thoughtful about wearing gloves when you inspect any lesions. You don't want your skin to be damaged so that if MRSA is in the environment of your clinic, it can get in through weakened skin areas. Okay? So, proper hand washing, hugely important. Okay, I would wager the family I was telling you about did not have proper hand washing or proper cleaning of surfaces in their home. Using barrier protection when you're inspecting lesions, or if you have a patient who has had a persistent MRSA infection, you might want to wear gloves whenever you palpate areas of their skin. That's not essential, but if they've got a steady infection, you might want to use gloves when palpating. That doesn't mean you need to wear gloves when needling, because you're not going to needle into the area of the lesion, and you're not going to get your hands all over that patient while you're needling. Okay? Any potentially contaminated material. So when a member of that family was on my treatment table, of course, the sheet, the paper, the pillows, the pillowcases, everything that they come in contact with had to be removed and or cleaned before the next patient could come in contact with it, right? Okay. Avoiding contact with draining wounds or other skin lesions, obviously. Using disinfectants on the surface of things and antiseptics on the human surface whenever needed. Okay? Referring possible cases to a physician. Now the other activity with a potentially contaminated material, which we'll skip over a little later because I'm talking about it now, is let's say that you've got contaminated material from MRSA, or maybe from a bleeding a episode that you did with one of your other patients, or you've got contaminated material from a hepatitis B individual who maybe, had some sort of episode on your table, either loss of bladder control or bowel control or throwing up or something, so that you have infected materials that need to be kept away from other individuals and need to be handled carefully in processing after that. You're going to take those and place those in appropriate protective, usually plastic bag that is marked with that big red mark from the regulatory agencies that says this is infectious material, and you're going to isolate it from other things. Okay, so you're not going to take a MRSA sheet and just throw it in your laundry. You're going to put it in an infectious materials bag and seal it and isolate it from your regular laundry so that it can get appropriately handled in the process. Okay. All right. Any questions about MRSA or any of the diseases we've covered so far? Okay. I think what I'm going to do is I'm going to go really quickly through some definitions. And then when we start in on the CNT protocols in general, I'll take a little break and let you catch up with your books for a few minutes, okay? So, general protocol, page 27, the definitions, which are urgent for you to understand, okay? We're going to go really quickly through these. Antisepsis, asepsis. Clean field, clean technique, contamination, disinfectant, sterilization. Disinfectant versus antiseptic. When we talk about cleaning things, when we're cleaning objects, we're disinfecting. Okay? You disinfect your table. You disinfect the surfaces of the room that you come in contact with, such as doorknobs, desks, etc. You do not disinfect humans, thank you. You use an antiseptic to reduce the microbial load on those humans' skin, okay? But you use a disinfectant to reduce the microbial load on surfaces in your office or on treatment surfaces that wherever you're working, okay? So all that this does is reduce the microbial load. It does not kill 100% of the microbes, okay? How many people heard me say that? Okay, those of you who are asleep or not paying attention, all right? Antisepsis, disinfectants do not kill 100% of the microbial load. That's a very important thing to understand. Okay? I think we actually need to have everybody stand up, please. Too many people are not even paying attention right now. Stand up. Take a stretch. I know it's long, and I know my voice tends to be slow and create lethargy, but try to stay with me, okay? So those of you who have not been making eye contact with me, who are busy having side conversations, please stop it so we can move ahead without me wondering why you're not paying attention. Okay, have a seat.